Savior, vexed with regret. Not long ago, in the sunny days of my youth, when the apron wasn't merely a piece of cloth, the stead not an ornament to adorn, they defined me. All my days, a similar routine, where nothing changed, apart from the faces of the afflicted. But that one face, that one day, is fresh in my memory like it were yesterday. Through the stained glass doors of our emergency, they rushed her in. A man who I presumed was her father moved every human possible. Her mother holding her hand, crying for help. The little girl, the patient, gasped for air, took in all that she could, all at once. Wheeling her through the chattering machines, waiting for the reports, wasn't time consuming. And we found it, the reason for her ailment, by just a touch on the X-ray machine. A collapsed lung, because you see, I am a doctor, a lifesaver, vexed with regret. We drained her lung and every procedure done, so that the patient could breathe. 3 hours of fighting, 4 hours of losing, there she lay lifeless on the bed with side railings and machines that stopped beeping. Formidable loss of their only child crashed her folks to the ground. Her mother cried in despair, her father ordealed in anguish, but alas, she did not move. The etiquettes of the hospital were adhered to. Her autopsy reports came through. I was adamant I wouldn't find anything new, because you see, I am a doctor, a lifesaver, vexed with regret. And there it was, the reason for their loss, the petite devil with a sly smile. A Chico scene? How could this be? How could the X-ray not say anything about it? I trusted it. And then it all came back. A voice in my head screaming. Wheezing sound, stethoscope, wheezing sound, stethoscope. Lying behind her trachea horizontally. Could not reach the vertical heights of my proficiency. Because you see, I am a doctor. A lifesaver, vexed with regret.
This was just one patient we spoke about. There are many others who suffer the same fate. Who do we hold accountable for this? Why do such shortcomings occur in the first place? Is it because we lack the decision-making skills and fail at clinical suspicion? Or is it because we prioritize a machine to do our job just because it is presumably efficient?
In the past, the 5 special senses were the forerunners in the analysis of an affliction. It is the 21st century, and we are entirely reliant on touch. From a meager check of time on our smartwatches to even paying bills with our smartphones, all we need is a touch. Ironically, we are neglecting the most basic and important of them all, the doctor's touch. It is this comforting touch, this affectionate touch, this reassuring gesture, which now unfortunately has become the missing touch.
Ours is a technologically proficient but emotionally deficient medical system. While investigations are excellent means for aiding the diagnostics, they should only be relied upon as a supplementary tool and never a direct substitute for physical examination. But today's scenario suggests something different, as we have countless cases of substandard care and overused investigations between the doctor and the patient.
For a system that believes in patient-centered care as a mantra, modern medicine is inattentive, at times actively different to patients' needs. A patient feels no less than a layman entering a government office, juggling between desks. He is lost, confused, and affronted by a brooding sense of helplessness. A patient is rightfully irritated as there is loss of money and resources. The course of this process then eventually makes way to loss of faith. Inevitably, the fundamental prerequisite of medical practice, the doctor-patient relationship, gets compromised. Communication gap is both the cause and effect of this, due to which An accurate diagnosis cannot be established with conviction. Hence, there is either a misdiagnosis or the diagnosis is missed as well.
All these processes have paved way for the ongoing crisis, where patients are even resorting to physical means against doctors. In such situations, the media only adds fuel to the fire, provoking the general public. To inquire further into the entire problem, we interviewed a few patients. Here's what they had to say.
आपको क्या हो रहा था? डॉक्टर ने आपको वहाँ पे देखा, हाथ लगाया वहाँ पे? हाँ, आपको संतुष्टि मिली फिर?
Last year, the prestigious newspaper Times of India conducted a study and reported that the average time an Indian doctor spends with each patient is a negligible 2 minutes. Health commentator Ravi Dugal ascribed this as to poor doctor-patient ratio. It is concerning that 18 countries, covering around 50% of the world's population, have a mean consultation length of 5 minutes or less, as reported by the British Medical Journal.
We conducted a survey amongst 200 students of our college, where 61% claimed that doctors neither gave them adequate time nor performed a physical examination to their satisfaction. 63% students agreed that medicine today is overly reliant on technology.
When we asked our professors, they collectively opined that medical students are chasing scores instead of being passionate about acquiring knowledge. Due to this, their sincerity and commitment to the profession is not up to the mark.
64% students accepted that they didn't feel as motivated as when they joined the course. 3/4 of them were ready to compromise on their internship in order to crack the PG entrance exams. Students these days conduct a proper physical examination only 60% of the times during clinics.
A Harvard study by Professor Jha showed that 5.2 million medical errors occur in India annually. In the Health World Supplement of Economic Times, Dr. Giridhar Gyani attributed this to inadequately trained doctors and nurses to measure the clinical outcomes.
Dr. Abraham Burgess claims that stories of shocking medical errors that commonly occur are because doctors either miss something during a physical examination or forget to examine the patient at all. He thinks of it as his worst nightmare, that a patient with a diagnosable or treatable condition will slip through his grasp.
The lack of clinical knowledge has been overshadowed by the advancements in medical technology. We can now see and evaluate the disease even up to a molecular level, thereby increasing the chances for a confirmatory diagnosis. This has lessened the physician's time for a hands-on examination of the patient.
With a better diagnosis comes a better treatment plan, and doctors are often convinced with the quality of treatment provided. But the real question here is, are the patients content with this kind of care? When a patient leaves the clinic, there is still a sense of discomfort, which can be attributed to the missing touch.
Stringent protocols and endless guidelines in modern medicine have coupled with the legislature in the form of Section 304A of IPC and Consumer Protection Act. Due to the internet and mass media, the patients are now aware of information that creates a frightening prospect among doctors of being summoned to the court.
Hence, the physicians are unable to resist the temptation of ordering more investigations than they usually would, creating a vicious cycle. The professional evil of cut practice, as well as over-reliance on paramedical staff, are deteriorating the situation as well.
If this continues, the future of clinical practice as a whole seems bleak. Introspect into the deepest corner of your heart and ask whether you can skillfully perform a physical examination up to the expected standards. In the coming years, we are going to be senior doctors, and young medicos are going to look up to us to guide them towards their dreams.
If we don't pass on the tradition of physical touch to them, how can they possibly teach their own pupils?
The judgment and interpretation of what you observe differentiates one doctor from the other. In the future, we could only end up being programmed machines totally reliant on computers for the interpretation of a report-based practice instead of an examination-based practice.
Being present is essential to the well-being of both patients and caregivers. Being present is fundamental to establish trust in all human interactions. Being present is integral to the art and science of medicine and predicates the quality of medical care.
The moment you feel like you're just another vision, it takes the soul out of many physicians' lives. Most often, your patients will never care how much you know until they know how much you care.
A doctor's blunder once cost a little girl her life. Did she ever triumph over the repulsive device against her impulse to revise her approach? Let's find out. Medicine and health sector is the undisputed responsibility of doctors. While we have welcomed computational and laboratory experts to galvanize our practice, we must remain vigilant that they don't encroach upon our duties to the point we are no longer required.
Let us protect the art of
Palpation.
Auscultation.
Let us bring back and preserve
the
the missing touch.
I can recognize some faces. Do you advocate use of a cap on the number of patients the doctors or clinicians can examine per day? And can you prescribe certain time limit for which each doctor has to examine a patient? Do you advocate use of a cap? Cap means how much time?
So there is no need of a specific cap. If you see the slide, the developed countries are giving 20 minutes while we are giving 3 minutes. It doesn't exactly matter how much time we are giving to them, as long as the patient is feeling satisfied when he leaves the clinic. So the communication with the patient, his proper examination and the satisfaction after leaving the clinic is important. So the study is based on 3 minutes or 5 minutes are given by the doctor, after which the doctor is only concerned about how many patients he is going to treat after this guy. So the patient in front of you never gets the desired attention that he would require on a regular basis.
But suppose this awareness itself is not there amongst the doctors regarding, so how you advocate bring that in? Should there be any regulatory measure, or maybe by law they are supposed to, because unless and until by law or by regulatory measure you put in some awareness, then only they will become aware as to, yes, I have to follow this also. Should there be any regulatory measure?
Thank you, sir, for the question. The symposium is in itself an initiative to spread awareness regarding this. And second of all, talking about laws, according to the MCI rules and regulations in chapter 1 point, I think, 11, it is said that lectures alone are not enough to teach the students. Now, if you teach the students, this is the basic level, if you teach the students, they'll follow this throughout their life. So I think instead of focusing on doctors, this is the time that we should now also initiate this with the students.
In fact, I wish to say that it is like back to basics.
Yes, sir.
Having said that, I could minutely observe that you said that we are spending almost 3 minutes. But you would also appreciate that what we learn is by watching our seniors, teachers, and other clinicians. So if my senior, my teacher is going to examine the patient for 3 minutes, there are maximum chances that I'm going to do the same thing for 3 minutes. So basic root cause is there. So what do you suggest to correct this kind of attitude amongst the teachers or the senior doctors to have such kind of favorable change?
Thank you for the question, sir. Sir, after studying about the solutions for this problem, we came up with one thing, where the Stanford Institute has started a Stanford 25 initiative. In this, the head-to-toe examination methodologies are given properly. So, instead of just being limited to the Stanford College of the United States, it should be spread worldwide, where the senior doctors should be given the guidelines of examining the patient thoroughly from head to toe. Only if the senior examines him properly, the juniors would learn. And if the juniors are learning properly, the students will automatically learn the trade. Thank you for the question.
Another basics we say is like when you perform assessment of the evaluation of the patient, it's basically 2 parts. One we call it as talking business, that's like history, and second one is doing business, that's examination. You missed this finding. They say that today's doctors are becoming more of counselors. That means they're ready to talk more rather than examine more. So what do you suggest to change this kind of paradigms? That people are smart in talking rather than examining the patients?
So recently, there was this change in medical curriculum where they included exit exam along with final MBBS exam. Now,
It's good you said that. You know, I always believe that probably they're doubting the integrity of the entire university education system by bringing in exit exam. Once university has certified a person as a doctor, has awarded degree, then what is the need for exit examination? That means you're doubting the integrity of the entire education system of the country. This is my personal opinion, even if I agree with that.
sir, I won't contrast your opinion, but I personally have an opinion that they are not wrong either. This is just to ensure that there are no fraud doctors. But rest apart, I just want to focus on the fact that exit exams don't only focus on MCQs, but they also focus on practical examinations, where they'll have externals come and examine us. So when they have practical examinations, students do study for practical examinations. So this is the whole point of having.
I congratulate the team for choosing such a topic, because this is the reality on the ground. Because whenever I am sitting in my cabin and I used to see the students, the patient walk into my OPD, in the dental OPD. From the other department, they directly see the radiograph. Most of the time it is OPGs. They directly see the radiograph and they directly advise the patient the treatment without clinically examining the patient. The two things are there. By clinically examining the patient, one thing is that every patient is different. Each and every patient is different. Each and every case is challenging. And the other thing is the touch to the patient. So the clinical examination is required. And the other thing you have mentioned here is that the patient is to doctor ratio. I don't think it is like that. I have even it is our habit or even I had observed that even the doctor is sitting without any work or doctor is sitting idle, but he will not like to see the patient. So it is that we people should change ourselves. Okay, we should work in that direction, and definitely the touch is required for the patient. Thank you for such a lovely presentation.
I just got one last point to say, because what he said is bringing up a very nice issue that is called we teach knowledge, we teach skills, but we don't teach attitude. So probably what is missing in curriculum is teaching attitude to young doctors.
So can I continue? Sir, our college has arranged a workshop tomorrow, which is the doctor-patient relationship, which would encourage empathy for the doctors towards the patient. So our college is taking steps towards improving this situation.